Folks, today we're very pleased to have Bianca Frogner with us. Bianca earned her BA in molecular and cellular biology with a concentration in neuroscience from Cal Berkeley, and she went on to do a PhD at Johns Hopkins in health policy and in health economics. Sorry. And following that was a postdoc at the University of Illinois, Chicago, in the School of Public Health there. She then went on to be an assistant professor at George Washington University, and also while there was a deputy director of the Health Workforce Research Center. She then, let's see, I'm skipping through your list here. She then moved to the University of Washington and became deputy director and associate professor, deputy director of the Primary Care Innovation Laboratory. And she also holds an adjunct appointment in the School of Public Health and was promoted to professor. Congratulations last year
Thank you.
in the Department of Family Medicine, and then retains the adjunct professor appointment in the School of Public Health. As the director of the Center for Health Workforce Studies, Bianca has been leading a team of investigators and research staff to understand how the health workforce has been evolving and ways to optimize the use of healthcare workers in the healthcare team. As all of us appreciate, healthcare workers, which include, of course, physicians, nurses' aides, assistants, have played crucial roles in caring for the health of the population during the pandemic, and have been enormously stressed and have faced many personal challenges leading to burnout as a result of the conditions under which they've had to work. Dr. Frogner will be discussing that with us today, what we knew about the healthcare workforce pre-pandemic, and then what's happened over the last 2 years. So I'm really looking forward to this. It's going to be enormously interesting. The title of her talk is "Where Did All the Healthcare Workers Go? Healthcare or Health Workforce Trends Before and During the Pandemic." So thanks, Bianca. Take it away.
Thank you so much for that introduction. And I'm honored to have this opportunity to give this Science and Medicine lecture. I do recognize quite a few of the names in the audience, so thank you so much for being here today. And for some of you, it may be familiar material, but I welcome conversation and chats that I can hopefully answer some questions along the way. So I will be talking about our healthcare workforce in a broad spectrum. And before I get into too many details about what I'm going to talk about, I did want to first at least acknowledge that some of the findings I'll be talking today are funded by the Health Resources and Services Administration, which is a major funder of ours. And so, of course, whatever I'm saying is only my point of view, not those representing HRSA. And again, some of the unpublished findings I'll be talking today is also in collaboration with a colleague of mine at University of Minnesota, Jeanette Dill. And any of the work that I am presenting today could not be done without my fantastic team at the Center for Health Workforce Studies, or CHOOSE, which has been in the Department of Family Medicine for a little over 20 years now, where our goal is to conduct health workforce research in a way that we can help inform health workforce planners and policymakers around the country to help strengthen our health workforce. And we're fortunate to be funded by 2 large grants from HRSA, one focused on the allied health workforce, as well as another one focused on issues of health equity and workforce diversity. Again, many of the studies that we conduct under these 2 grants are informing my my talk today. In addition, we have other grants and contracts that, again, have allowed us to look at the full spectrum of healthcare workers. So I'm going to first start off by just defining a little bit of who I'm talking about when I say the healthcare workforce, because I think it's sometimes helpful to take a step back and think about how we can define or identify people who work in healthcare. And this is just one set of definitions, and there could be other ways to do it. And I will acknowledge that there are certain groups that are missing from my definition here. So generally, when I'm talking about the healthcare workforce, I think about it within a somewhat confined structure that's defined by the Bureau of Labor Statistics through a set of codes. I can almost tell you the numbers of these codes off by memory because I've studied these numbers so many times. But one way by which we can look at the healthcare workforce is to look at it by industry. And these are defined by the North American Industrial Classification System, or the NACS codes. And these are the industries that reflect more direct care settings. And as of 2019, and I'm using 2019 as a baseline because things really kind of changed over the course of the pandemic, we were at about 17 million people working in healthcare. And that's spread out across multiple settings, hospitals really being a fairly dominant sector in and of itself, at about representing about 44% of the entire pie. Now, ambulatory care makes up multiple settings: outpatient centers, offices of physicians, dentistry offices, as well as a number of other ambulatory care settings. And while each is its own sliver of the pie, when put in aggregate, we're again at another fairly large 1/3 to 40% or so of the healthcare workforce. And then the last third or so of the health workforce are those who work in long-term care. And long-term care is consisting of nursing care facilities, residential care, as well as home care services. So whenever I look at the healthcare workforce, I tend to include these three major sectors: hospitals, ambulatory care, and long-term care. Now, I do want to acknowledge that those who work in pharmaceutical companies, insurance companies, or healthcare tech companies are not represented in this picture. So that is a group that I'm not able to look at very carefully. Another group that's worth mentioning too are those who may work in drugstores or like pharmacies that are sit in retail settings, because that's also a difficult group to identify. Another way to slice and dice the healthcare industry is to look at it by occupation. These are using standard occupational classification codes. So again, out of that 17 million people, I think where we tend to see the most concentration of our discussion of the healthcare workforce are the physicians and the RNs. Now, physicians out of that 17 million represent about 3.6% of that overall pie. And our registered nurses, including the advanced practice registered nurses, they make up about another 16%. Now, in combination, that's about one fifth of the total pie. And RNs really are the one occupational group that is the largest singular group out of all the occupations that make up the healthcare industry. So oftentimes we do hear a lot about what's happening in the nursing workforce, in part because of this large representation. What I will be talking a lot about today are those who fall in our healthcare support occupations, which is about a quarter of our health workforce. And there are many different types of aides and assistants that fall in this category of workers. Nursing assistants are among the larger group, but also other titles you're probably familiar with here are medical assistants, as well as home health aides and personal care aides, among others. And I want to just highlight the importance that when you put them together, you realize 1/4 of the pie is a fairly large representation of our healthcare workforce. And I just want you to keep that in mind as I move forward. So the question everyone really wants to know, and we're often asked, is, are we facing a health workforce shortage, especially in this pandemic period and into the foreseeable future? There's a question I get asked a lot. And so I'm going to talk about some signs that might give us a sense of whether a shortage exists or not. Now, it probably would help if I gave a brief definition of a shortage. A shortage basically means that the employer's demand for healthcare for workers generally outweighs the labor supply that's available. Now, in healthcare, employer demand is driven mostly by patient need. So as patients get sicker, or especially say during COVID, employers have needed more workers. And what potentially drives down labor supply is the size of the pool of qualified, willing, and able workers. Now, this is a very simplistic definition of a shortage, but at the fundamental level, we're really talking about that employers are asking for more workers than what's available. So what contributes to low labor supply? Well, there are many reasons, and I'm just going to highlight a few in particular. So first, starting with the pool of workers. Now, we've seen during this crisis that many of our healthcare workers have been directly affected by COVID illness. And since the start of the pandemic, I've been trying to track the number of healthcare workers who have been directly affected by COVID, both by catching COVID themselves versus dying from COVID. And the Center for Disease Control has been tracking these numbers. It's been a little spotty in terms of where exactly the numbers are, but the latest numbers, if you go to their website, is that we're at about 1 million healthcare workers who have contracted COVID since the start of the pandemic. And out of those, 3,500 or so have passed away. Now, this is likely to be an undercount. And I say that because if you go to CDC's website, they have a separate section that talks about the number of deaths and cases among nursing home staff. And you'll see that the number of nursing home staff cases is over the number that was on the last slide. We have over 900,000 folks in the nursing home settings who have been reportedly catching COVID. And the majority of deaths seem to be happening among the nursing home staff. Now, some of this has to do with the methodology by which we are counting or collecting data around COVID cases and deaths. And I could probably have a whole talk just on that by itself. But it is worth noting that I think most people would at least acknowledge that nursing homes have been very much a center of COVID illness. And I do want to say early on in the pandemic, we tried to get a handle on where these numbers may go. And I had some initial projections that I had put out, and I really underestimated how many cases we probably would have seen in the nursing home facilities. I guess fortunately, I overestimated the number of deaths. But so some good news and some bad. What I really realized at the beginning of the pandemic, and even now, though, is that it's really hard to have projected these cases. Now, all this being said, I do want to at least give just a moment of remembrance and just take a few moments of silence for those healthcare workers who lost their lives on the front line, since this was such a critical last couple of years where many have sacrificed their lives. So if we could just take a few moments, that would be great. All right, thank you so much for just taking that moment. So there are many, as I said, other contributors to why we may see a low labor supply within healthcare. And I'm not going to go to each one of these in detail, but rather give a high level description. So another reason why we may not see an available pool of workers are competing responsibilities at home for childcare, as well as for caregiving responsibilities for other elderly family members. Then there's probably a pool of workers out there who are not willing to work because of issues where they're feeling morally distressed, they're feeling burnt out, and ultimately experiencing moral injury. And some of this is driven by potential safety concerns that people have with their own lives in terms of actually experiencing COVID, which, as I just mentioned earlier, we do see a good number of people who have been directly affected by COVID. And other potential reasons why we are seeing a low labor supply relate to having enough qualified applicants. And this can be because there's not enough training available. Like many nursing schools or schools of nursing have struggled to accept more students. They've had plenty of students apply, but they haven't had enough faculty available to actually take on as many students as they would like. So even if they wanted to increase the supply of nurses graduating, they don't necessarily have the faculty to do so. Also, sometimes it can take a long time to train up our workers. I mean, if we're saying we're in a low supply of physicians, it takes multiple years to try and train up a supply of physicians to fill in the gaps. But we also have a number of restrictive practice policies, which I'll talk a little bit about later in this talk today, that may also affect our pool of qualified applicants. And all these topics have been talked about in quite a number of ways within the media. And I actually give the media quite a few reporters out there have done a really good job to articulate what is happening on the ground for healthcare workers. And they've been reporting fairly consistently over the last 2 years about health workforce struggles. And in 2020, a big emphasis were on nursing home workers in particular, identifying the struggles that they've been experiencing with catching COVID themselves, and then the staffing shortages that were resulting from that. Now, more recently, so this is probably just in the last few days or last few weeks, a lot of the shift of the conversation has been focusing on the hospital workforce and the challenges that many hospitals are facing, particularly around keeping their nurse staff in place. And I'll come back and talk a little bit about this, some of these details more later in the talk. Now, what do the numbers actually show in terms of the direction we seem to be going with the healthcare workforce? These are numbers that are taken from the Bureau of Labor Statistics. I have to say, I can't take credit for the design of this type of graph, as I've seen others kind of display things in similar ways. I just try to update the numbers through December 2021, which is the most recent time period. But what this is showing you is the number of workers in any given month since the start of the pandemic relative to January 2020, which I'm just using as a baseline. So this just gives you a sense of how much have we changed in terms of the number of people employed across different settings of the healthcare workforce relative to where we were at the beginning of the pandemic. And as you can see, almost most sectors experienced the bulk of the loss of jobs in April of 2020. That really was the first peak of the COVID pandemic. And at that peak, we lost 1.4 million healthcare jobs. And so since then, many have tried to track to see what has happened since then, and including our own team. And in this graph, you'll see kind of a darker red color. That just represents all other private sectors other than healthcare, just to give you a sense of what happened in the economy writ large. And for the most part now, by about November of last year, we're seeing that dark red line start to cross the red line, which indicates kind of where we were last year. So most of the rest of the economy seems to have recovered to the number of jobs we were in January of 2020. Other settings that seem to have recovered are offices of physicians, as well as all other ambulatory care settings. Now you can see hospitals in yellow still remains below where they were pre-pandemic. And probably the most concerning are those who work in nursing and residential care facilities, where they are about 87% to 90% of where they were pre-pandemic. So that number in particular has been concerning because, as you can see, that blue line has been consistently on a downward trend since the beginning of the pandemic. I want to note, though, and acknowledge that I'm sure my colleagues, especially who work in family medicine, probably feel like, oh, yeah, you say that we're recovering, but I sure don't feel that way. I think that's fair because while it's great to be above that red line, ideally, and before the pandemic, healthcare has been growing at a pretty rapid rate. So we might really be expecting that we should be at about 1.05. So in some ways, we may be below where we have been, where we would have been otherwise if the pandemic was not here. And these numbers don't really tell you anything about the need, the patient need that may have increased over time, where we need a workforce that's more than what we had before. So I do want to just acknowledge that just crossing the red line by itself does not mean necessarily that we're all okay. But I do think in particular where I'm concerned are those nursing and residential care facilities, and this will be a theme that will come back again and again. So I do want to show just some results from an unpublished study. It's under revise and resubmit right now, where I did this work with Jeanette Dill at University of Minnesota, where we used the current population survey, which is a publicly available survey collected by the Bureau of Labor Statistics. It's a monthly household survey with a complex sampling frame that allows you to monitor people, the same person from month to month for a series of months. And so we took advantage of this sample to look at those who said that they were employed in healthcare in 1 month, and then they reported this next month that they were either unemployed, or out of the labor force. Now, unemployed does mean that you're looking for a job and you're available for work. And leaving the labor force, it means that you're not even looking anymore. But we combine the two together in part because the distinction is a little bit messier during the COVID crisis. I think not only in terms of how it was collected, especially earlier in the pandemic, how these two categories were identified, or how people identify themselves in these categories, but I think COVID has just added a level of element that it's possible that more people were leaving the labor force because they felt they can't find work because it doesn't have the, say, safety requirements that they're looking for to come back in. So I'll, again, talk a little bit more about that later. But here we look at what we're terming leavers across 3 different time periods. We have a pre-period that basically represents the year prior to COVID, again, a bit as a baseline to give us a sense of what the leaver rates were at that time. Then we looked at the first period past the peak, or right as the peak of COVID began, through the end of December 2020. And then we're have a third period of time here in 2021. So these are 3 cut points. We could have probably tried different cuts, but I didn't necessarily see a big difference, say, where exactly those months were. But this gives you just a sense of the trends that were happening over time. So I'm going to run through a series of graphs that just gives you a sense of what leaver rates look like by different cuts of the data. And here in this first cut of the data, I'm going to show you healthcare leaver rates by sector. And what you generally see here is that during the entire period of time of our study, those who worked in hospitals in 1 month, their leaver rates were generally lower than any other sector of the economy. The yellow line represents the long-term care industry, and you see that this number, the leaver rates, are continually increasing, which is, again, reflective of what I showed in the prior graph, where you saw total employment numbers are on that continual decline. So in some ways, this is just reassuring to us that the trends in terms of the leaver rates continually going upwards, meaning more people are leaving in long-term care, is consistent with the other data that are available. Now you can see for ambulatory care, they saw a fairly quick recovery overall, but again, the number of people leaving, or the rate of people leaving, is still outpacing where it was pre-pandemic. Now we broke down leaver rates by occupation, and the couple points that I'll make here are those who are in those aides and assistant positions. So those that I talked about earlier, that make up about 25% of our workforce. You see that they have had consistently higher leaver rates than any other occupational group. And there are a couple other occupational groups that are not reflected in this graph, but aides and assistants still popped up to the top. Now, the yellow line are LPNs and LVNs, or licensed practical nurses, licensed vocational nurses. And you see that by the end of the survey period that we looked at, their leaver rates have only slightly recovered, and they're probably among the slowest groups to have recovered. Now, physicians, and this was a little bit surprising to us, is that physicians are actually seeing a continually increasing rate of leaving healthcare jobs. And so this is something to note. So while they have the lowest leaver rates in general, the fact is ticking upwards. And maybe it's not surprising to the audience here, but it was a little surprising to us to see that actually pan out. And on the other hand, for registered nurses, where we hear a lot of talk about how there's a concern that registered nurses are leaving in droves, we don't necessarily see that pan out. But this has been somewhat confirmed also by another group of researchers who published recently in Health Affairs, who basically came to the same conclusion using very similar data, but slightly different approach. Now, looking at the leaver rates by race and ethnicity, I know there are many more lines here, but I'll talk you through a couple key points. One of which is the lowest line there, the light blue line, represents white healthcare workers, and that white healthcare workers have generally seen lower leaver rates than any other racial or ethnic group, meaning that they left their jobs at a slower rate than other occupations. Now, Asians, they saw a fairly heavy spike in leaver rates in the middle of the pandemic, but have largely recovered at this point in time. Our Native American or Pacific Islander healthcare workers have seen fairly consistently high rates of leaving their healthcare jobs compared to other occupations. And our Black healthcare workers are probably alongside our Latino healthcare workers, among those who are experiencing relatively slow recovery rates for during this last period or most recent period of time. Now, we also broke down the data of healthcare workers by their self-reported gender, as well as their by the number of children and their ages of the children in the household. And where we found the most striking information and is consistent with the broader economy and what's happening there is that both men and women with children under 5 have been experiencing higher leaver rates throughout our entire study period, but they have experienced among the slowest recovery across all other groups of families. And women in general also have experienced higher leaver rates than men, regardless of having children or not in the household. Now, a question that really kind of posing in the very beginning of this slide of my presentation was asking, so, where did they go? And I did want to make sure I actually addressed that direct question. And it's something I've been trying to monitor using, again, the current population survey and taking advantage of the fact that that survey allows you to see what industry and occupation people may have had a year apart. And here I just list the 3 top industries to which some major healthcare occupational categories have moved to if they did in fact change their jobs. And for physicians, when they're leaving their healthcare job, where they're moving into primarily is education. And education doesn't mean that they're going back to school. That's a different category. In this case, this means they're working in the education sector, most likely as maybe a professor or another kind of teacher. Among the other common places that physicians have moved to are pharmacies / drugstores. And this one is a little puzzling to me because it shows up a couple other times, but this can represent potentially your Walmart, your Targets, your Amazons. I'm not entirely sure where this is. It's a relatively new thing for me, given that I have looked at movement of across all these occupations into different industries. And the fact that pharmacies and drugstores are popping up is a relatively new thing. And so it does make me wonder if this could, to some degree, be driven by an Amazon. So that's something to dig into a little bit more. And finance is another area that physicians have moved into. For registered nurses, we're seeing them also move into education, meaning they're going back to teaching, possibly. We're also seeing them move into public administration jobs, as well as into management careers that are outside the healthcare spectrum, at least outside of management, say in a hospital or management in ambulatory care settings, but they could very much be still working in a management sector that may still touch on healthcare. So whether they actually are losing their or dropping their RN skills is not entirely clear. For LPNs and LVNs, as well as our aides and assistants, which in this data set is specifically focusing on nursing and home health aides, the top place where individuals have been going is individual and family services. And I do want to note that of those LPNs and LVNs who left their healthcare jobs and among nursing and home health aides, the attrition was actually quite high from their actual occupation. Most of them were leaving their occupation altogether into a brand new occupation just within these other industries. And among what was maybe somewhat promising is that about 25% of the LPNs who moved on went on to actually become a registered nurse. This is one of the few glimpses I've seen actually where we see this movement to a higher level career and is somewhat encouraging. For the nursing and home health aides, however, about 25% of them went on to become a personal care aide, which in a lot of ways is just more reflective potentially of where their setting is, where it is in that individual and family services sector, meaning you're working in the home. But it does suggest that perhaps they're giving up some of the more direct care skills that they were probably otherwise doing in a nursing or home health aide job. So just in a summary of these findings here, although new and I do want to acknowledge, is that there are new workers entering over this time period. I focus specifically on leavers, but some of those leavers could have also re-entered over this time period. And to some degree, we know that many of them have. However, leaver rates, the fact that those are remaining at a higher level than the pre-pandemic level is a area for concern, because that means that we haven't quite recovered to where we were pre-pandemic. Physicians also are the only occupational group that we're seeing an increasing rate of leaving. And that is also an area of concern. In long-term care, similarly, that's the only sector that's seeing an increase in leaving. And I would say we do not find very many physicians in long-term care. So this is mostly driven by, and likely to be driven by, the LPNs and LVNs, as well as the aid and assistant workers in these sectors, which are all struggling to recover. And as I mentioned, healthcare workers of color, as well as healthcare workers with young children, particularly women, they're leaving healthcare at a high rate. But this has a lot of intersection with long-term care and aid and assistant jobs, where we know that we see a higher proportion of our healthcare workers of color in these aids and assistant jobs, particularly in long-term care. And most of these jobs are majority, if not practically 90% of them, are women. So again, highly correlated. So one question I have been thinking about over time is, could we have seen this coming? And I would say yes, at least in long-term care. Some years ago, when I was still at George Washington University, I partnered with my colleague Joanne Spetz at UCSF through their Health Workforce Research Center. And we looked at the same data, the current population survey data, between 2003 and 2013. So 10 to 20 years ago of data. And at that time, so just keeping in mind that, I mean, we've been struggling with issues in long-term care for decades. And if, at least for me, studying it in this way, looking about 2 decades ago of data, that was suggesting at that time that we were actually seeing people leaving at a faster rate than they were entering in long-term care. So this is a problem that was predating the pandemic. And what was particularly concerning to us at that time were that among those who were leaving this is just one cut of that data. So those who were leaving out of home health care or nursing care or residential care facilities, about half of them were leaving in a state of unemployment or leaving out of the labor force. That's concerning because that means that they're not moving up into some other higher skilled job, which is what one might hope otherwise. And so it was a signal that there's something broken in this sector. Now, just trying to get a sense of what risk healthcare workers were facing probably during their time in these jobs, we looked at various measures of financial risk. And one point I want to make in particular is the rate of uninsurance in long-term care in particular. And that's the dark blue lines. The dark blue lines indicate the percent of workers either in full-time or part-time jobs who are uninsured. And you can see that particularly part-time workers in long-term care, about 17% were uninsured and 13% full-time workers were uninsured. And this just gives you a sense that healthcare workers in these settings did not necessarily have a lot of protections, say, to prepare themselves when COVID came about, in terms of not only just not having PPE, but possibly not even having the insurance that they need to go get the care that they need, let alone having a provider, say, having a regular source of provider care. So these signals were already concerning and things I had been talking about for years prior to the pandemic. So in some ways, I can't say I'm so surprised that some of what we have been seeing in long-term care continues to persist during the pandemic. And I wanted to point out that also pre-pandemic, healthcare jobs have long been on that list of top fastest growing jobs as projected by the Bureau of Labor Statistics. And what, again, was concerning to me in particular was that the home and personal care aides were among the fastest growing jobs. And it actually dropped a little bit over the years. And and if you were to look at current projections now, healthcare actually really isn't even at the top right now, for a number of reasons. But for home health aides, were projected to be in high demand by the Bureau of Labor Statistics. And what was concerning to me in particular is if you look at their wages there, it's $25,280 as the median pay in 2019. So these very low wage jobs were very much in high demand. Knowing that this group was in high demand, but yet we saw them leaving at a high rate, and potentially were also facing quite a bit of financial risk by not being insured, among other things, has been an area of focus for me to just monitor how can we do better by these workers. And again, pre-COVID, this is in 2019, there were some headlines that were already suggesting that there were challenges in the long-term care workforce, with headlines saying that the shortage of home care workers is worse than we think, and that there's a caregiver shortage. So again, pre-pandemic, we probably could have seen this coming. And so this gets me to what can we do about that? I wanted to try to leave on a more positive note by giving some sense of the ongoing efforts and reimagining a little bit of the future. So again, I'm just going to revisit this scale of shortage. And again, shortage is a very complex term because I think a lot of people are looking for a yes or no question, answer to that question. They want to know, do we have a shortage or not? It's way more complicated than that. And not just because patient need is sometimes hard to project, and as well as the pool of qualified workers, but there's so many factors that can really tip the scale either way. And wages has been a conversation point that I think many people have been talking about. But in addition to changing wage structures, there are also a number of policies, technologies, and the availability of substitutes that could be discussed to change this tipping point, as well as thinking about the distribution of our workers. So I just wanted to revisit my earlier slide where I talked about the various contributors to a low healthcare workforce supply, and just give some example ways by which some of these factors could be addressed through various policies. And this is just a smattering of them. For example, being directly affected by COVID illness to some degree could have been mitigated by providing paid sick leave. Childcare and other caregiving responsibilities. Well, if there were more childcare benefits, perhaps this could also have mitigated some of these issues. A pool of non-available workers because of burnout, moral distress, or moral injury. This goes to talking a little bit about workplace culture and seeing what can we do to improve the workplace. Because while burnout tends to indicate that it's an individual's problem to address, the conversation is shifting more towards thinking about moral injury as a way to say, it's not just about the individual worker. When you're seeing mass numbers of people expressing concerns that they're burnt out, that there's probably something in the work environment that could be addressed. For safety concerns, this goes to having adequate PPE, but also making sure that we have enough vaccine education and the availability of vaccines for our healthcare workers. And in terms of lack of qualified applicants, we can do things like invest in education and training programs, as well as revisiting some practice policies. And this is where I want to spend just a little bit more time. So in our center, we've done a number of reports actually tracking the changes in scope of practice, regulations, and just other ways by which different policies were relaxed that allowed different segments of our health workforce to be more nimble during the COVID crisis. And so we did 3 specific reports on the physical therapist workforce, respiratory care workforce, as well as thinking about the pharmacist workforce. This was all done under our Allied Health grant. And I want to encourage you to read it. I don't expect you to read it all here, but this is just to say a number of changes were made during COVID to allow flexibility of our workforce, and that we need to review the outcomes to figure out whether or not how this may have increased access for patients and may have resulted in hopefully good quality of care, but we need to monitor whether that was really the case or not. But in addition to these various types of occupation-specific ways by which they were expanded during the COVID crisis, we also need to just revisit our general scope of practice rules in general. I know this can be a somewhat unpopular topic because, and as I've seen many occupations try to fight over territory, but I think there's a bigger opportunity here where there's a lot of care that's still needed to be given. And we need to think about whether scope of practice rules by themselves are really the most effective way to ensure high quality of care. And I think especially in the case of the COVID crisis, where we've relaxed some of these laws very quickly, we need to ask, why was that possible to do? And why was it okay during the COVID crisis, but not okay long-term? And that if we do scale it back, is it going to be potentially harmful back to the workers themselves, as their skills that they were able to use during the pandemic are no longer able to be utilized and expanded upon post-pandemic? So these are things that we need to investigate further to determine whether the relaxation of scope of practice laws has had any detrimental effects on our society. And my colleagues and I at other universities who also do health workforce research have commented a little bit on how addressing scope of practice rules may allow us to ensure and sustain a pandemic workforce, but also long-term. I also want to highly encourage folks to check out the Washington Health Workforce Sentinel Network, and shout out here to the Health Workforce Sentinel Network team who are on this call, including Sue Skillman, Ben Stubbs, Amy Clark, who have done fantastic work to get this up and running here in the state. It's been a long time initiative in collaboration with our Workforce Training and Education Coordinating Board, which has fortunately dedicated a good number of resources to thinking about healthcare workforce issues in the state. And this is now a program that has state funding to keep it going. And what it really is trying to do is identify early and fairly regular, up-to-date signals where healthcare employers are struggling with health workforce issues. So we're regularly surveying healthcare employers across the state of Washington, across a number of industries, asking them where they're struggling with their healthcare workforce in terms of vacancies, retention, and recruitment, trying to identify which occupations and the reasons why they're struggling. But in addition to all that, we also identify ways by which they're trying to actually address these issues. And this is where I wanted to just give some examples of things that different settings have reported, seeing that have worked or that they've tried as a way to address workforce challenges during this pandemic. So these are just some select characteristics. This network is so rich in information, so I do want to encourage folks to check it out. But again, these are just some smattering of examples to give you a sense that there are ways by which we can actually address health workforce challenges here in our state, but also elsewhere. For nursing homes and skilled nursing facilities, a question that I'm pulling out here are ways by which these organizations have used recruitment incentives like sign-on bonuses during the pandemic and what they're finding to be successful. And while nursing homes have used sign-on bonuses, as well as many other settings have used sign-on bonuses, they found generally that this wasn't enough, that there had to be actually a move in wages, as well as thinking about ways to create career pathways for workers, using things like apprenticeship models to help people move along that career path, and just really invest in their health workforce, the existing one that they have, rather than just bringing on new workers. Another just set of examples comes from our small hospitals, where we asked how policies or regulatory or payment changes could be done to improve and strengthen our health workforce. And here they identified that having more funding for training programs would be helpful, as well as improving reimbursement rates. And insurance reimbursement rates definitely comes across as a topic across many settings. For primary care offices, among the questions I'm just pulling out here is asking what other kind of retention strategies might have been used during the pandemic. And many different strategies were reported. Pay increases were a little less commonly used in primary care offices. I imagine it may have something to do with the way reimbursement is also structured. But among the things that they did try to move are things like medical benefit offerings, as well as reducing the costs for care to their employees in their practice, as well as doing things to build teams and support their workers in their own wellness. So this is to say that there are many ways by which we can address our healthcare workforce needs. And it's not just about increasing wages. So I'm coming here to the final thoughts here of my talk, where I just want to leave you with some key points. The availability of healthcare workers has significantly fluctuated over the course of the pandemic, and we have not yet returned to pre-pandemic levels, which is why I think we still feel this sense of urgency that we're not where we need to be, that we seem to feel like we have a shortage of workers. And it's hard to predict, though, the long-term trajectory of where healthcare delivery may be that may impact future demand of healthcare workers. But it does seem like we're at least on the path to recovery generally. But we do need to think about our skilled nursing facilities. And although many of you may not work directly in a skilled nursing facility, this does have ripple effects across the healthcare system. If you cannot discharge your patient to a skilled nursing facility, you're stuck with them. And that adds burden to your workforce. So we do need to figure out how to solve that area. And also, my worry a little bit is that as the economy recovers, we will likely see more competition from other sectors. This generally has been the case, that as the economy strengthens, healthcare loses workers to those other sectors. Why? Because they often offer higher wages and better benefits. But also within healthcare, we tend to compete a lot with each other. Hospitals do tend to be a place where many workers are lost to from nursing homes, partly because, again, the pay is better in hospitals than they are in skilled nursing facilities. And this is particularly true for our aides and assistants who have low barriers to entry. So they're committed to their jobs because of personal, desires to be in a caring industry. But the training involved in their occupation is fairly low, that moving to another occupation in another industry isn't a huge lift. And so we do need to think about how to better support our aides and assistants and keep them in our industry, in particular because they play such an important role to our healthcare teams. And I imagine many of our physicians and nurses who are feeling the sense of burnout may be experiencing in part because they just don't even have the support that they need on their teams. Like, who's going to fill the cabinet, the supply closets? Who's going to do the scheduling? If we don't have the people there to do that work, that's going to be felt across the healthcare team. And lastly, there are strategies to retain workers. People are implementing them during this pandemic. And if we deploy them effectively and across settings and learn from each other, we may be able to prevent any sense of a real shortage. And that raising wage is one element to help address this, but we also need to address some disparities in wages that are very highly correlated with the leaver rates that we're seeing here, as well as given that wages are fairly limited by insurance structures, and it may not be the best, so easy to pass on costs to consumers the way other parts of the economy can do it. Well, fortunately, the good news is that this is not the only way to really retain our healthcare workers. And so from there, I'll stop. Thank you so much. I know I covered a lot of ground, and I'm happy to answer any questions.
Thanks, Bianca. We'll wait for a minute and we'll see if people post questions in the chat. Please put your questions in the chat and Bianca will be able to answer them, but maybe one or two to start off with. There were about 1 million cases and you thought, you counted that as an undercount in one of your early slides in healthcare workers, but I wonder how that actually pays, on a rate per 1,000 or 100,000 to the general population, and which might give insight as to whether or not the infections are acquired on the job or off the job.
Yeah, so that's a good question. So I did try to do some quick number crunching to get a sense of how the rates compared. And generally, healthcare workers were infected at a lower rate, quite a bit lower rate. It was like 1/10 the rate of what the general population was experiencing. As well as death rates or the case fatality rates is also quite a bit lower than the general population. Now, what is hard, I think, about the data collection piece of it is that those who did acquire it in the community, we may not know what their job was. I mean, I think about how I had been tested for COVID a few times. Nobody asked me what my job was. So how did
Right.
anybody know? I mean, I'm not a direct care worker, but how would anyone know that where I worked?
Yeah. One other question, and Matthew, I'll get to yours next. In the slide that showed that very precipitous drop early on in the pandemic, I think the depth, that low point was right around March of 20. Um, and that's interesting to me because it was so early.
Yeah,
And do you have a comment to make there? And then, we've
yeah,
been recovering ever since.
yeah. So
So
I
that
think,
was almost before you could get burnout depending on where
yeah.
you were and how acute. Yeah.
Yeah, well, that's a very good question and a fair point. So the big issue was furloughs, and here in
Uh,
Washington State, Sue Skillman really led some of the work where we got data from our employment security office, where we were tracking unemployment rates, and a lot of it does have to do with people who are just unemployed because all the clinics closed, and so that's
yeah.
why, particularly in ambulatory care, they saw such a large suffering of that. So it really is more the ongoing effects that probably is where we need to pay more attention, because that's where the issues of burnout are starting to come
Yeah.
up clearly.
Yeah, that's point well taken. I
Yeah.
think that should. So let's go to Matthew Thompson. Are other countries facing the same challenges as the U.S.?
As far as I can tell, yes. So I haven't done a careful read of all those countries out there. I have talked to our Canadian colleagues up north, to their health workforce folks, and everything I've said here has definitely resonated with them up there. Where I would say it seems like maybe they might have a system that provides more, say, universal health care to their workers, that seemed to solve some of their problems, but not all of them. That they didn't necessarily see having more access to healthcare as necessarily a panacea. So I do think other countries are still struggling a bit with how best to care for their workers. At least our Canadian colleagues.
Great, thanks. So recognizing that the biggest hit is really in skilled nursing facilities, but setting that aside, Peter Asselman asks about what do you think the impact of the increase in telemedicine and changing the workforce has been?
Yeah, so that's a great question, because clearly telemedicine was adopted very quickly and very widely across ambulatory care settings during the pandemic, as we've tried to figure out how to expand care. I think studies are still out in terms of what that did for overall flow, and it's going to be very difficult to disentangle, say, how telemedicine has made people necessarily efficient, because COVID care has been kind of intertwined with the regular everyday care. So to try to parse out how it improved care for people who did not necessarily have COVID, it's just going to take some work. But clearly that was a huge success story probably that comes out of the COVID pandemic, is that we managed to get telehealth more widely spread. So a lot more work should be considered. And I will add to that, the scope of practice laws definitely touch on that, because one of the reasons we were able to spread telehealth was allowing more providers to get right onto their telehealth platforms without the oversight needed. So we need to just monitor how to keep that going in light of scope of practice changes.
Yeah, that was a remarkable step in the right direction that
It was.
the pandemic brought about. One comment. I think it surprised everybody to see that physicians might have been leaving kind of the practice of medicine and going into pharmacy related jobs.
Yeah.
It's interesting, to know what the definition of those jobs might be, because I could see, for example, pharmacy benefits managers maybe,
It's
and
possible.
pharmaceutical industry. So that one would be interesting.
Yeah, so I wondered that too. I went back to see if someone worked for the pharmaceutical industry, would they show up in that pharmacies group? And I think that's possible. I think the pharmacy benefit manager one is an interesting question too. I don't know a lot about pharmacy benefit managers and would love to learn more. It seems so complex, but I would love to dig in more there. I just even did a basic Google to say, like, do physicians go back to become pharmacists? That seems funny, but that should have showed up in a different way. They would have gone back to school, and that did not seem to be the case.
So, Ben Dunlap, let's see. And I could connect you with folks in the School of Pharmacy, but just drop an email over there and you'll get to the right place. Um, Another concern that may also play into burnout are mandatory overtime clauses, which are intended to keep coverage of shifts, when a worker leaves. But of course, those accelerate burnout by just keeping people on the job longer. So, question as to whether or not you have data in this regard. Um, and create anything about creative solutions to that mandatory overtime issue.
Well, unfortunately, data are hard to come by to know what policies may drive hours worked. What we may be able to look at more are the changes in hours worked over time. So rather than overtime, just over the time period. But it's clear that among nurses in particular, that they're really struggling with this sense that they're feeling very overworked. And I think a lot more will come to light over time to understand how these mandatory rules have affected burnout among nurses, and whether there are things that other kind of guardrails that need to be put in place to prevent, while they may work more hours, to then prevent them from having to come back to work right away and to not take on more patients than may be safe to do.
Okay, so question from your boss, Paul James,
Yeah.
in the Q&A. And sorry,
Yeah.
I didn't open this up earlier.
No, it's
Um,
nice.
inadequate system for long-term care in the U.S. causes the hospital system to be less efficient with inability to discharge, as you noted. But he's asking, are there more efficient national models or state models that you know of for improving long-term care?
So I think there are a lot of great pilot programs that exist out there. I think what we don't seem to see is a political will to move them into national scale. So I think there are quite a few examples, and I'm not probably the best one to speak to all those examples out there, but I do want to acknowledge that uh, people have been thinking about long-term care and how to improve it for decades now. And what at least really became clear to me over the last couple of years is somehow long-term care just doesn't have the political
Yeah.
firepower to move and make changes.
So question here, I'm curious about how lever and recovery rates have fluctuated across geographic regions like rural versus suburban. And maybe, where people are vaccinated versus not.
Yeah, those are good questions. And we do have a study ongoing. Davis Patterson will be leading that study in our center, where we're going to look at COVID recovery or COVID rates, case rates, and try to associate that with the availability of healthcare workers. And it doesn't quite answer this question about levers, but we are trying to understand the rural versus urban experience as it relates to the availability of healthcare workers. So unfortunately, at this point in time, I have not done that cut.
Yeah, and this last question, about the specificity of policies kind of or strategies geographically, do you think those have to be developed, kind of geographically, or one size fits all policies to kind of address, let's say, the lever rate in long-term nursing facilities?
I think we're going to have to do a number of strategies. I think localities know their needs the best, but there's clearly lessons to be learned across regions that we can apply more widely. Try and find ways to share those strategies is challenging. I think that's where the Sentinel Network has been particularly useful, is that people can look to say, oh, that's happening over there in that setting or in that part of the state. I think having forums like that is really important.
Yeah, great. So I want to thank you once again very much. Very
Thank
interesting
you.
talk and very topical. And also thank the audience. A good rate of questions to take advantage of Dr. Frogner and her expertise. So thanks very much.
Thank you. I appreciate it.
Okay. Bye bye
All right.
all.
Bye bye.